Good afternoon, everyone, and thanks for joining us for the second in our series of LGBTI webinars for people working within PHNs and PHN areas. Today we are looking at LGBTI Elders, and to present on this topic today is the manager of our Silver Rainbow project here at the Alliance in Ageing and Aged Care, Sam Edmonds. So I'll hand over to Sam.
Thanks, Beck, and good afternoon, everybody, and welcome to this afternoon's session again. Silver Rainbow is a national LGBTI Health Alliance's Ageing and Aged Care projects, as Beck said, and we're funded by the Department of Health. This project rose out of the first national roundtable on LGBTI ageing and aged care, and also the first national strategy, which is still currently going and will finish in June next year. As Beck said, my name is Sam. I'm the manager of Ageing and Aged Care at the Alliance of the Silver Rainbow project. And I look forward to sharing this session with you. Now, just apologies for a few seconds while I bring up my slides. Sorry, folks. Okay. So these are the 5 principles under which the project works, which are also the 5 principles of the National LGBTI Ageing and Aged Care Strategy. And these are around inclusion, empowerment, access and equity, quality and capacity. As I said, so Silver Rainbow are the Ageing and Aged Care projects. There are 2 actual projects that the Alliance runs. There's what we call the Strategy Project, which is around educating and information at all levels of government and to the broader community and to LGBTI communities and people around inclusive practice and what this might look like. And so we monitor the rollout of the strategy, and we're also funded to deliver certain aspects of it. We also do LGBTI ageing and aged care awareness training, and this is operated right across Australia in every state and territory. And to access that training, I will have a slide at the end which will have all our partner names on it. And if you would like that, then I recommend you contact our partners. We also have an online e-module which can be found through our website and also through ACON's website. I'd just like to start by acknowledging the traditional owners of the land on whatever country you are now watching this presentation, and pay my respect to elders past and present and to any elders that might be watching and participating today. I'd also like to acknowledge our LGBTI elders and to honour them, because without their strength and resilience we would not be where we are today. So we talk about diverse bodies, genders, relationships and sexualities, and this is what we mean by LGBTI. Many people don't use the language of LGBTI, and you may have heard words like queer, questioning, gender fluid, agendered, etc. It's also very true for LGBTI elders that they will use different terminology as well, or use the terminology we know in different ways. So it's really important to just be aware of how people talk about themselves. So as I said, most older Australians do not fit LGB and don't well, they do fit LGB, apologies, but they don't necessarily self-identify with these terms. So sexuality may or may not correspond to the labels or terms that people use to personally or publicly describe themselves. And they may use a range of terms, or they actually might prefer no terms at all. However, most people who fit as LGB, so lesbian, gay or bisexual, do not identify with these terms, and this is, as I said, very true of elder people. If someone has expressed to you that they have diverse sexualities, ask them how they prefer to be referred to, if at all. Also with LGBTI elders, many have had attractions without relationships and relationships without attractions. And this is very true for elders who have grown up over the last, 40, 50, 60, 70 years, where the expectation was that you got married and you had children. So a lesbian woman may have got married to a man and had children, and she would be in a relationship, but there wouldn't actually be any attraction there. It was just what society expected and what they did to blend in with society. So there's a range of reasons that elders hide their sexualities and do not feel confident or able to express them. Sometimes this expression does not happen until much later in life. And for some people who develop dementia, they may find themselves sharing their actual sexualities as they're no longer able to self-censure. And I'll talk a little bit about this later on when I do sort of touch on issues around being an LGBTI elder with dementia. And it's also really important to know that some people might use the same words differently. Quite often today we refer, when we're talking about gay people, we're talking about men, but often with LGBTI elders, or oftentimes with LGBTI elders, gay might be a word that a lesbian woman would refer to herself as. So as I said, it's really important to talk to the elders and find out the language that they use. I was going to do this as an activity, but unfortunately, because of slight technical issues that we had when this session was meant to be going to air, I've just made it more into an information provision. I've still left it as a question and answer, and it might be something that you could use within your services just to, I guess, help people explore what it's like growing up as an LGBTI person over the last 70 to 80 years. So it's really about helping you understand the social changes an elder has experienced over their lifetime. And I'd like you to imagine that you are someone who identifies as lesbian, gay, bisexual, transgender or intersex, and that you were born in 1939. So in which decade were aversion therapies in the form of electric shocks used to cure people of homosexuality? So in the 1950s, at age 12, you were in a society where you could be sent for treatment to be cured of your homosexuality. And in fact, you could still be cured right up until the mid-1980s. In 1973, when you're 34 years old, the term homosexuality is finally removed from the Manual of Mental Disorders. In 1998, when you are 58 years old, homosexuality is finally decriminalised in Tasmania, and same-gender sexual activity is actually finally decriminalised across the whole of Australia. In 2009, when you're 70 years old, you can finally have your family relationships recognised with the legal reforms that occurred in that time as a part of the same-sex, same entitlements inquiry and report from the Human Rights Commission. In 2012, when you're 73 years old, your needs and issues as an LGBTI elder are finally recognised and to be addressed within the ageing and aged care sector. So imagine that, so 1939 right up until you're 73 before all aspects of your life are actually recognised and treated as the same as those that are non-LGBTI. However, today at age 76, probably a little bit older, you are still considered to have a mental disorder called gender dysphoria if you're a transgender person, and those that are intersex still are faced with having unnecessary genital surgeries to normalise them to fit in with what we consider to be a normal male or female body. So as you can see, there have been huge changes in the life of an older LGBTI person, and they have lived through a time in our history when they suffered stigma, discrimination, criminalisation, family rejection and social isolation. They learn to hide their sexuality, their gender or their relationships to be safe and to protect themselves. And it's really, as I said, not until now that an older LGBTI person is living in a world where there are some protections and recognition of their diverse and individual needs. But as I said, those who are intersex are still have stigmatising language used to identify them, and this leads to poor mental health, marginalisation and exclusion. And they obviously still face unnecessary surgeries. And again, noting that people who are transgender, gender diverse, are still be faced with being termed as having a mental disorder. So it's really essential for you working with older LGBTI people to understand the impact of this history, past and current, on older LGBTI people when they start using your services. And these are just some of the headlines that people would have faced throughout their lifetime. So not only are they living this in their sort of immediate life, in their public and social life, but they're also seeing this portrayed across the media. Basically that being LGBTI is wrong, is different, should be punished, should be cured. In terms of culturally and linguistically diverse people, this is just a map of all the different genders that are in the world, and it's showing all the different cultures that recognise more than 2 genders. And in fact, in some cultures, up to 5 genders are recognised. Within Aboriginal and Torres Strait Islander communities, there are 4 genders, and I will talk about this a little bit more in another slide. So in working with LGBTI elders, there's also a cultural overlay. So not only are they coming in with this history of life experiences, but they may also be coming from cultures where being a gender that's not male or female is perfectly accepted and part of that culture, and they might have roles and responsibilities within that culture. And then coming into a Western culture that doesn't necessarily recognise this and the impact that would have on their general health and well-being. This map is just showing a map of lesbian, gay and bisexual, laws that impact more directly on lesbian, gay and bisexual people. Apologies. There are 196 countries in the world, and in approximately 81 of them, LGBTI or LGBT people face imprisonment or the death penalty. And only 69 countries actually have anti-discrimination laws around being LGBTI. The red countries is where people can face the death penalty. The sort of skin-coloured countries, people can face 14 years to life imprisonment. The light orange, people can be imprisoned for up to 14 years. And the dark yellow, it's imprisonment, but we don't know the length, or in fact the person could be banished from the country. Green is about marriage, it's where there's marriage laws. The light green is where there's a substitute that's equal to marriage, and the bright yellow is where there's a substitute that's not quite equal to marriage. In sort of China and that sort of area, that's the very light yellow, there's actually no specific laws around being LGBTI. Well, that was when this map was developed in May 2015. So this is another cultural overlay that elders face as well. So there's the life experiences of what's going on, their life experiences in many countries around the world. And then over that, you've got these other cultural experiences where you could face a death penalty or imprisonment. So these things are really important to consider in terms of someone's willingness or ability to talk to you about being LGBTI, because certainly there will be high levels of fear, especially when dealing with institutions, as to whether to disclose or not, and how much that person can trust you. In addition, where there are laws around marriage, this doesn't necessarily mean that there is full equality for LGBTI people. There still might be other laws that undermine the benefit that some of the marriage laws provide. So just because someone comes from a country where there is marriage recognition doesn't necessarily mean that there aren't other laws that would make them feel that they can't trust you or your service, and that you know their experiences. So as I said, in Aboriginal and Torres Strait Islander communities, there are 4 genders recognised, so brother boys and sister girls. So sister girls are assigned as males and live part or all of their lives as female, and brother boys are assigned as female and live all or part of their lives of male. And they also have a unique societal role within community. So it's really important, again, that different cultural overlay, to think about the impact of being an LGBTI elder, being Aboriginal, being old, and the multiple and interconnecting issues of discrimination that person will be facing or has faced in their life. So what does this all mean? In summary, an LGBTI person who is currently receiving aged care services or thinking about entering or getting services through a PHN or a health service grew up knowing that they could be imprisoned or forced to undergo medical cures if their sexuality, gender or relationships or intersex status was known. Homosexuality was considered a mental illness, so people found to be gay, lesbian or bisexual could be subjected to attempted cures like aversion therapy. Apologies. Elders note that their sexuality or gender identity might be confronting for service providers and feel it's their responsibility to avoid this upset and to educate service providers about the needs and experiences of LGBT people. And you can also think of the impact that might have if every time they're going into a service, their feeling is that they're having to avoid you feeling uncomfortable, and then they have to educate you about what their needs are, and that continual pressure as they're accessing. This sense of pressure to hide sexuality or trans intersex status to avoid discrimination or upsetting others is not a problem faced by the broader community. And it may contribute to a reticence on the part of LGBTI people to describe their needs, report discrimination or identify service gaps. So they might not actually let you know what's actually going on or the experiences they faced or where someone might have discriminated against them within your service. So it's really important that service providers understand LGBTI histories and the belief of some LGBTI people that their sexuality, their relationships, their bodies and genders should be withheld. With this understanding, service providers are well placed to communicate a message of welcome and safety to LGBTI elders. In addition to facing discrimination on being LGBTI, there's also the issues of ageism, not only within the general community, but within LGBTI communities as well. Both communities very much have a culture of youth, and being young and active is the way to be. And as you know, when you become an older person, you suddenly lose so much, and there's a particular perception and way that we talk about older people, which isn't actually accurate now or probably historically. So it's really important also to think about not only the impact of being LGBTI, but the impact of ageism from all communities. So not only from the general, but from within maybe the community that you're a part of, or the people you're a part of, and their attitudes towards you. And obviously this can lead to increased social isolation and loneliness. And obviously it impacts really badly on all areas of an elder's health and well-being, because there is nowhere that they can escape from that ageist attitude. The other issue that really needs to be considered is around LGBTI elder abuse. I know there is an inquiry into elder abuse in general at the moment, but there are some particular issues that LGBTI elders can face. In terms of the abuser, they can threaten to out the elder. So elders often feel safer hiding they are LGBTI, and they can often feel that it's better to be abused than others finding out that they are LGBTI. And this has a particular impact on grandparents that might be LGBTI, because they could be outed to their children and then lose access to their grandchildren. The abuser can also say authorities won't believe the elder, and often a lifetime of abuse and or discrimination by authorities will keep an elder silent as well, and they won't tell that they were being abused. They can use the elder's fear of being alone, and it's reinforced by hearing from society in general. There's this attitude that if you are LGBTI, you will end up alone. So this reinforces that negative attitude. And it's also easier to isolate an LGBTI elder, as often family may already be estranged, and because LGBTI elders are not comfortable in settings that do not cater for them. They'll avoid health professionals. And it's possible that for LGBTI elders who have limited experience with being LGBTI, so maybe they've come out much later in life, to be told that abuse is actually a normal part of being LGBTI, and this can be used to keep them silent. The victim also can be, it's not contribute, but the victim's own beliefs and attitudes can also impact on their ability to come forward and talk to you. Internalised homophobia, biphobia and transphobia can therefore impact on an LGBTI person, because they're seeing within themselves from society that being LGBTI is not normal, is not good. Think of the news headlines I showed previously, and believe that therefore they don't deserve better than the treatment that they're getting. Rejection from family, society and institutions actually develops a really strong sense of self-reliance, and this almost becomes a survival method, and then they become fearful of involving others in anything that's going on in their lives. So if you suspect abuse, then it's really important to establish a strong relationship of trust, and this can only happen if LGBTI elders feel supported and included from the moment that they walk through your door. So when they walk through that front door, or they walk through into your office, is there anything there that is going to indicate to them that you're an inclusive service, an inclusive practice, an inclusive person, and that therefore you will be safe? So really be aware of these particular issues and work with linking the elders with services and LGBTI supports. So LGBTI elders do experience different health outcomes, but not as a result of being LGBT or I, but as a result of discrimination. So in addition to the usual issues facing older adults, such as loneliness, isolation, loss of autonomy, and increasing dependence, older LGBTI individuals may experience further stresses. These are usually associated with sexuality or disclosure of their sexuality and their relationships and or their gender identity and or intersex status to healthcare providers, discrimination, lack of legal recognition, and little, if any, protection of lifetime partnerships, and obviously limited opportunities to meet other LGBTI people. Anxiety and depression, as would have been touched on in the first of these series, is very high within LGBTI communities. So a US study found that 66% of LGBT older people had experienced victimisation multiple times over their life, and 82% at least once. The same study found that 33% of older LGBT people reported depression, and nearly 40% had contemplated suicide. So when elders discussed what contributed to this anxiety and depression, many of the factors they identified were common with those shared by the broader community. So these included the loss of someone close, a childhood that involved family tension, bullying or sexual abuse, a family history of depression or mental illness, the experience of illness, pain or disability, and life pressures including relationship problems or family and economic tensions. However, older LGBTI people face unique challenges as a consequence of discrimination, pathologizing and criminalisation as that they have faced due to their sexuality, relationships or gender identity or body. Elders describe the influence of societal values on their early years, the pressure to conform to gender norms and their desire to fit in. They recounted homophobic and transphobic abuse ranging from subtle harassment to violence, which in one case in this study led to death. In this context, participants reflected on the need to hide their sexuality or gender or body in order to be safe, and the effects of these experiences and obviously exacerbate anxiety, depression, and their sense of self. There was a recent study done by Dr. Catherine Barrett, which is called We Are Still Gay, and it is available online if you'd like to access those resources, which include a number of videos as well as some written resources. These can be found at the Opal Institute. The impacts of sexuality were explored, and participants were invited to respond to the suggestion that lesbian and gay people straighten up or become heterosexual when they develop dementia. Against this view, lesbian and gay participants described the constancy of their sexuality and their sexual attractions. The failure to recognise this constancy of sexuality for lesbian and gay people living with dementia was experienced as devaluing and unhelpful. The flip side of that is where there is unintended disclosure. So those carefully considered decisions about disclosure relied on by an individual to protect themselves. When there is a significant level of cognitive function decrease, the experience of the dementia can then result in many people inadvertently disclosing that they are LGBT or I. And sometimes what we hear is that it's the dementia making the person LGBTI. It's not the dementia making the person LGBTI, it's the person has always been LGBT or I, and when they've developed dementia, they're no longer able to protect themselves and self-censor, and they let people know. So it's really important to work with where that person is at and be aware of those perceptions of either straightening up or becoming LGBTI, when in fact the person is always the person they were. The importance of respecting gender identity in the study was also emphasised, and trans participants expressed concern that this was not appreciated by service providers. So several people interviewed outlined the challenges confronting transgender people living with dementia. One service provider described how a client sought medical services to transition while experiencing symptoms of dementia. The client soon had difficulty remembering the decision to transition and struggled with the realities of having begun that process. So it's really important as a health profession to screen for dementia and also to work with where that person is at. So if they're starting to struggle with that, then work with them at that point in time. Other participants described how transphobia and the ignorance of families and service providers affected how gender was expressed. One service provider shared the story of Edna, a woman in her 80s living with dementia who had transitioned 40 years earlier. She was given an ultimatum by her son to present in residential care as a male or never see her grandchildren again. Edna conceded to her family's wishes, but the service providers acknowledge that the facade of living as a man and the stress of a family situation negatively impacted on Edna's health and well-being. Unfortunately, Edna's experience is not unique. Other research has documented how families of origin may capitalise on the vulnerability of trans people living with dementia to enforce their own ideas about gender. In these situations, it's really important that service providers, health professionals are well placed and need to advocate for the rights of trans people to live in their affirmed gender. So to achieve this, it's really important for you to consider how your personal beliefs about gender impact on the services you provide and how you interact with people. And it's also important that you shift your focus from trying to understand gender identity and why someone happens to be transgender to supporting a client's wishes. Such support is likely to require staff education and advocacy with families and other clients within your services. And it may also involve ensuring strategies for personal care where that's part of the process and support to maintain that person's gender experience. The other key issue for predominantly trans and gender diverse and intersex elders is long-term hormone therapy. So hormone therapy may be used by transgender people as part of their transition to maintain physical changes and to support their emotional and psychological well-being. And intersex people obviously may also need hormone therapy. Gender-affirming hormones such as testosterone and estrogen are important for bone strength. This means that for transgender people who have undergone gender-affirming surgeries, and for some intersex people, hormone replacement is required to maintain good health. Long periods without hormones can decrease the level of necessary hormones and consequently increase the risk of osteoporosis. Furthermore, sudden cessation of hormones can increase depression and in some cases suicidal feelings in transgender people. And this really can be an issue when transgender or intersex people are admitted into hospital or move into residential aged care. However, long-term use of hormones is also believed to increase the risk of other diseases, such as cancer and cardiovascular disease. Therefore, this should be considered as part of intersex and transgender elders' care and ongoing health support. It's also important to think about other necessary medical checks for elders, and particularly trans men might needing pap smears and breast checks, and that trans women have prostate checks as well. In terms of palliative and end-of-life care, we do have a position statement on our website that you can access around our beliefs of what good palliative and end-of-life care is for LGBTI elders. But in some states, there is a hierarchy of people that can be contacted to make decisions on behalf of a person. And this often starts with the spouse. And even though the law might not intend it to be a hierarchy, it's read as a hierarchy. And this is really problematic for LGBTI elders if they're unconscious or unable to state who can make a decision. In addition, their partner might be really fearful of actually saying that they're their partner and have an ability to have a say over that person's care, especially if the biological family is unaware of or disapproves of the relationship. In addition, often the grief of a same-gendered partner is not acknowledged or addressed, especially where the relationship may be hidden. Those situations where people may come in and someone will refer to the person with them as their good friend or their close friend or their supporter rather than their partner. So it's really important to establish that the person has an ongoing relationship and not to prioritise the biological relatives over anyone else that might be with that person. Again, you may need to become the advocate to ensure that the LGBTI elders' wishes are upheld. And it's obviously really important if you're working with people towards that end of life or palliative care that they've actually put together their documents that are needed. So in New South Wales, their guardianship, their advanced care directive and their advanced care plan and their power of attorney. And obviously it's different in different states and territories, but also they have, very similar responsibilities. So it's really important that you check with someone if you're working at that end of life or that palliative care that they have these documents in place and you know who their next of kin in terms of their decisions are. So for LGBTI elders, They're more likely to be single and live on their own, though this is changing somewhat, and they're much less likely to have children. And again, this is definitely changing. So intimate relationships have particular significance in the lives of LGBTI elders because they provide a protective space against discrimination, and it's one of the few places where diversity is affirmed. Despite this importance, some elders describe how their family of origin still do not recognise intimate relationships. This lack of recognition was experienced as hurtful and devaluing of their sexuality. The refuge provided by intimate relationships, coupled with a fear of discrimination, means that elders rely heavily on their intimate partner for care. In one particular research study, a person called Dale, a 72-year-old lesbian, reported that her long-term partner's care needs were almost impossible for her to manage at home, but there was too much fear for that person to bring other people in or to go into a service. She described how her partner died before it was impossible for her to stop, for her to continue to care, but she said it got very close. Dale cared for her partner at home because her partner feared discrimination if she entered aged care facility or even if she needed to go into hospital care. Most intimate partners believe they have a vital advocacy role for their partner, particularly in challenging homophobia. Indeed, many express concern for LGBTI elders who do not have a partner to advocate on their behalf. Service providers who understand the experiences of LGBTI people living with dementia and their life experiences and the life experiences of LGBTI elders in general are well placed to advocate for their rights. The other thing to just be aware of, and I believe this might have been touched on at the last presentation as well, is around families of choice. Where the relationship, where the family of origin or biological family has broken down, LGBTI elders may form a family from friends, extended family members and partners, and that becomes their family of choice. And it's really important to establish who that family is and who those people are when working with an LGBTI elder. LGBTI elders also carefully consider whether or how to disclose their sexual orientation, gender or intersex status to service providers and or the broader community. For some, this information is not shared until a rapport is developed and they feel safe. Additionally, transgender elders often identify only as male or female rather than as trans, and choose not to disclose their gender history because they want their affirmed gender recognised and respected rather than the sex they were. Apologies. Elders say that the physical reliance on service providers, especially in hospitals, means their bodies or their same gender relationships often get revealed without choice. The fear of disclosing sexuality and gender are associated with significant stress for elders as well as their partners. And disclosure involves more than simply having a tick-the-box sex or gender category checklist or relationship checklist. Again, it's about providing safe spaces for LGBTI elders. And in this instance, some elders may be willing to fully disclose their sexuality or gender and service needs. So providers need to understand this distinction in order to develop LGBTI inclusive services and to promote full disclosure of needs, because often the health needs of the person won't be recognised or won't be properly treated because they're so busy trying to protect themselves from that unintended disclosure if they're not feeling safe within your service. Studies also show that a significant number of LGBTI people have experienced discrimination in healthcare settings and so, again, conceal that they are LGBTI. And as I said, this can have a significant impact on the quality of care they receive and the ability to be screened appropriately. LGBTI elders are therefore less likely to be screened for common health conditions, or they'll absolutely present at the last minute when treatment is required. So what can you do to be inclusive for LGBTI elders? When talking to LGBTI elders, an overriding theme is that of respect. People need to be supported to be themselves and be respected for who they are. And this means treating all partners with the same respect. It's also important that each person is supported to be themselves and that staff don't make assumptions about them and their life experiences. Assumptions are often made that all gay people are similar or have had similar interests or histories, and this is not true. It is considered absolutely paramount to recognise the individuality of each person the complexity of their lives and their experiences, and the experiences that have made up their histories. As no two non-LGBTI people are exactly the same, no two LGBTI elders are. Documents need to capture the social histories of LGBTI elders as well. For example, registration forms which offer only the choice of married or single do not reflect the life experience of a person who has or has had meaningful same-gender relationships. The needs to have relationships, especially involving partners, recognised and is important. And this impinges directly on an elder's anticipation of the way they will be treated by a service. Sending a message of welcome is important. Older LGBTI people are unlikely to disclose all of their needs to the service unless this actually occurs. Elders have recounted difficulties in the past in finding service providers who could help them or who welcome them appropriately. The highlight was finding open-minded and accepting services as opposed to cold and rejecting ones. Elders see staff education as the key to providing appropriate person-centred care for all individuals, and this education should cover all employees in any care context, including auxiliary staff, and including all levels from management to direct care. The other big issue, as I touched on at the beginning, was around language. So always challenge the use of trans, homo and biphobic language. Use language that reflects how people describe their own genders or bodies. So check before using words that assumes a person's gender, such as mother, father, girlfriend, same-sex couple. Be aware that genders may change or people may consider themselves agendered or not identify with a particular gender. Never ask someone what their real name is or their real gender is. When you're using pronouns, don't presume what a person's pronouns are. Ask what their pronouns are, how they like to describe themselves, how they talk about themselves. But be aware that this won't necessarily be the same in every situation. They may say in a private situation they will use these pronouns, and in a public situation they may use different pronouns. So always check in with the elder. And if you're unsure of a person's gender, ask gender-neutral questions, such as what name do you like to be called, or how do you like to be addressed? And when asking about family relationships, ask about who are the important people in your life. Who is family to you? Don't require people needing to identify as LGBTI. Allow that relationship and that rapport to develop so that they feel comfortable in doing that. It's also really important to have an LGBTI inclusive practice policy. And in doing that, you really need to consult with elders from each of those different population groups, and to establish a working group that includes LGBTI elders and their carers. A good step is to review all your existing policies and procedures, because there may be stuff in there that unintentionally excludes LGBTI elders as well. And we do have a fact sheet on developing an LGBTI inclusive practice policy. It is obviously aimed more at ageing and aged care services, but can certainly be adapted for health services. And I believe this has been put up on the PHN section of our website. So what else can you do? It's really important to have visual cues and cultural practices. So when someone comes in through your front door, are they seeing pictures of LGBTI people around your office? Are they seeing brochures or documents or other things that indicate that that office is inclusive? When they're greeted at the reception desk, is the language appropriate and inclusive and doesn't presume anything about the person? As I said, and I keep touching on, the ongoing training and staff development is really important. Maybe within large facilities too, having champions, so people that can ensure LGBTI inclusivity is practiced within your service. And also really important to have policies that address the right to privacy, to sexual expression, to intimacy and to relationships. And again, that real important thing of recognising the person's family, the family that they have chosen. Finally, make sure you have a policy for patient-to-patient discrimination, as well as staff-to-patient and patient-to-staff. How will you react to, how will you deal with discrimination that happens within your service or within your office or within your facility? Really important to prominently display your non-discrimination or inclusive practice policies. Again, it's that walking in the door and knowing that the elders are feeling safe. Have resources on the specific health needs and concerns of LGBTI elders. And again, you might talk with a group of elders to find out what that would be and what would be useful. And if you can't provide a service, or the service is something they need other services, help the elder to find respectful providers of healthcare. It only takes that one negative experience for the person, especially elders, to then completely disconnect from the healthcare system and not re-engage with it until it's absolutely, at the sort of almost not the end point, but that point where the treatment might be at a level that could have been much simpler if they'd come in earlier. So these are our training project partners I was talking about. So in Queensland, it's QAC. In Western Australia, it's Gay and Lesbian Rights, GLBTI Rights in Ageing. The Northern Territory AIDS and Hepatitis Council in the NT. Transgender Victoria and Gay and Lesbian Health Victoria in Victoria. Working It Out in Tasmania, Uniting Communities in South Australia, and ACON in New South Wales, and the AIDS Action Council in the ACT. This is from a movie called Gen Silent, and one of the people says, there's a moment when a person decides to share their life or hide it. This will determine the rest of their life. This is that moment when they come through your door and they decide whether or not your environment is safe, whether or not you're inclusive, whether you treat them respectfully, whether you interact with them respectfully. And if that moment is a bad moment, then that's when, as I said before, you've lost them from your service and probably from accessing other services as well. So really important from that first step, that first phone call, that first walk, that first document they receive, that it's seen as completely inclusive. And this is just a little shot from Uniting, who was involved in Mardi Gras. So it's getting that message across that you support people, that you support them as they are, and you welcome and celebrate diversity. And just to finish, it's really important that you as an organisation come out so the person doesn't have to. So you're out there saying, yes, we are LGBTI inclusive, here's everything that shows we are, so the person doesn't have to say that they are, because they know that they will be treated respectfully and correctly. So these are the contact details. If you want further information, also from our Silver Rainbow aspect part of the Alliance website, you can get that information. Please feel free, happy to send on additional resources or other information, or to answer any questions as well. So thank you. I hope you found this useful, and as I said, please contact me if you'd like any more information or details.